All right, we're going to get started. We have these are sort of fun talks because we have our fellows talk, and David Zhao has been a terrific fellow. He's a spine fellow with us. He came via. I'm not going to say I cannot. I'm going to massacre the name, but he grew up. He was born in China, grew up in the San Francisco Bay Area and went to UCLA where he made the dean's list. Then off to Georgetown where he got his master's degree, got his medical degree, and did his residency with several people that we helped train. Um, and then some that I know very well, great program, and then came here to be a fellow and has been a terrific fellow. He's going to talk about full endoscopic versus traditional thoracic discectomy, and he's looking at the outcomes from a multi-center perspective approach. And this should be quite entertaining, so very interesting. So thank you, David, for giving the talk. I really appreciate it. All right, take
All
it
right.
away, my friend.
Thanks very much, Dr. Ellenbogen, for the introduction. Very excited and honored to be giving the Grand Rounds talk this week. So I'm just going to get right into it here. Uh, I'm going to start with some epidemiology and pathophysiology, and then talk about the traditional approaches from 360 degree for thoracic disc herniation, and then switch gears and talk about full endoscopic transforaminal approach, detail some of the safety and efficacy, just looking at the literature of the transforaminal approach for thoracic discectomy, and then go over some cases, and then finally report some of our patient-reported outcomes data from our Spine Healthy app. So thoracic disc herniations are rare. Then they account for about less than 1% of all disc herniations, cervical, thoracic, and lumbar. And thoracic discectomy itself is actually an uncommon procedure, which accounts for less than 5% of all disc herniation procedures. And when I read this, it actually surprised me. Having been trained at a large academic neurosurgery center and then coming here as well, you see these types of cases with some sort of regularity. If this just something to think about when you go out into practice, whether it's private practice or hospital employed and not a major academic center, these are going to be on the rarer side. Average age of surgery for patients is about 48 years old, and males are about equally afflicted as females. Depending on what you read, 30 to 70% are calcified, and 5 to 10% will have an intradural extension, just something to keep in mind. And the majority of thoracic disc herniations are found at T7 or below. Patients will report back or flank pain, radiculopathy, myelopathy, or combination of both. The majority of thoracic disc herniations actually remain dormant or decrease in size. And this was pretty surprising to me as well. So given their uncertain natural history, there really aren't any well-established evidence-based surgical guidelines for thoracic disc herniations, but some single-center treatment algorithms do exist. And this is in contrast with, let's say, cervical disc herniations or lumbar disc herniations. And surgery for thoracic disc herniations is indicated for patients with worsening progressive myelopathy, radiculopathy, or a combination of both. So getting into your posterior and posterolateral approaches, this is just a pictorial representation of sort of the amount of bony resection that's required. I cross out laminectomy because laminectomy alone for thoracic disc herniations is actually not recommended. If you can imagine, once you remove the lamina, you're just kind of staring at dura, and to resect a disc herniation is going to require some medial mobilization of the neural elements. You can get away with that in the lumbar spine, no problem. But in the thoracic spine, you're obviously dealing with spinal cord. And so spinal cord doesn't really do too well with that sort of insult. So moving a little bit more laterally, your transpedicular approach, this is probably going to be your workhorse. And this can get you a good amount of ventrolateral access with removal of a portion or the whole pedicle itself. I'll talk a little bit about transpedicular in a moment. Moving on to costal transversectomy, even more lateral, removal of the transverse process and then part of the rib head as well. And then lateral extracavitary, getting even more lateral, getting out, a couple centimeters of the proximal rib. And this is going to allow you some very, very sort of ventral and medial access to either remove disc or corpectomy or both. And for costal transversectomy and lateral extracavitary, given the amount of bony resection, you should always consider instrumentation just to stabilize the spine after this sort of surgery. I thought this was a a very good basic science paper that was published in the Spine Journal about a decade ago. But this was a quantitative analysis of the posterior lateral approaches to the ventral thoracic spine. In red is a shaded area of the amount of bony resection that you can expect from laminectomy alone, laminectomy with medial facetectomy, the transpedicular approach here in C, costocentrectomy in D, and then lateral extracavitary in E. What I thought was really interesting in this paper was they also looked at, in a cadaveric study, the variation in the mean exposure of the ventral spinal canal. And then this red line is going to be looking at your maximum approach angle. So as you get more lateral with your bony access, it makes sense that you're able to get, more sort of ventral and then even access these central disc herniations. So transpedicular approach, this is a nice figure taken from a paper in Neurosurgical Focus. This really details a mini open transpedicular approach. So if you have a disc herniation at T8-9, let's say, your pedicle of access is going to be the one immediately inferior to that. So it's going to be a T9 transpedicular approach. Typically, for a mini open, you're going to start with the hemilaminectomy, and then medial facetectomy. You can take up to half or 2/3 of the facet, and then the rostral half or a portion of the pedicle. Sometimes you'll need to get some of the body out as well. And so, doing a partial corpectomy allows you to pass your instruments here. This is your reverse angle curette, finding that plane, separating the dura from the PLL and disc, pushing it anteriorly away from the spinal cord, and then just, resecting it with the pituitary or a grasper. And that'll allow you to get a good amount of ventral decompression there. So moving on to your anterolateral and lateral approaches, transthoracic approach typically requires an access surgeon, typically requires dropping a lung, and these can be pretty morbid surgeries with the large incision and very, very long recovery. These can be done thoracoscopic, but I'm going to be very honest, during my residency and also here, I haven't seen one of these approaches. I think what's become more favorable is your lateral retropleural, and this can be done mini open as well. Juan Uribe has a nice paper and a couple of videos that sort of show this approach, but this is kind of the gist of it here. You're going to be getting access, in your pleural cavity here, dissecting along the endothoracic fascia, and this will allow you to, work ventral to the cord and do the work that you need to do. Not going to go into too much detail about this, but switching gears. So this is a pictorial representation of, sort of what you'd expect with the transforaminal endoscopic discectomy here. So this is your endoscope. It's a 30-degree foraminoscope. It allows you to see kind of around the corner. It's a 6.3 millimeter diameter, and then not shown here is your working channel, and which is going to allow you to maintain your access in the Campbell's triangle in the foramen, and then you can take your endoscope in and out with your instruments. Instruments are going to pass through this working port here, and then you're going to have continuous irrigation. And so ideally, when you bring in your working channel and your endoscope, you're going to be docking at the ventral SAP pedicle, and then you can tailor this sort of access point to your pathology here. But how do you get there? This is your Jamshidi, and under fluoroscopic guidance, you're going to be bringing in your Jamshidi to this access point right there. And then the inner stylet's going to come out, your guide wire is going to come in, your cannula comes out, and then these guiding tubes allow you to sequentially dilate up to the level of your working channel. Keeping in mind that you have your bony reamers that will allow you to ream away some of the bone of the ventral SAP here. This pictorial representation just shows a paracentral disc herniation, the amount of bony sort of resection there that's afforded with your reamers. And then this is your working channel that comes in. You're able to visualize the disc as well as the neural elements here with your endoscope. And then with any sort of medial angulation, you're able to really get this paracentral disc herniation, even central disc herniations, and even look contralateral with this transforaminal approach, which is extremely elegant. This is a picture that I took in the OR with the Sawbones model, and this was just after a case. You can see from a posterior view, you can just really appreciate the ultra minimally invasive nature of this approach. You're going to have sort of a caudal angle that that will allow you to get work away from the exiting nerve there. And then from an oblique view, you can just see the docking point at the ventral SAP in the pedicle there. And this is another pictorial representation of what you're able to get here. So this is the exiting nerve here. This is the pedicle here. This herniation is here. This is your working channel. And this will really allow you to, visualize not just your neural elements, but also any sort of disc herniation, remove it. You have direct visualization. You're able to treat these paracentral and central disc herniations without destabilizing the spinal column. And I think in the thoracic spine, it's a really, really elegant approach. And so I spent a little bit of time in the pharmaceutical industry right before medical school, and the FDA has a very, very well-established approach to making sure that drugs are safe, and these are through these randomized clinical trials, phase 1 through 4. Phase 1, is it safe? Phase 2, does it work? Is it as good or better? And then phase 4 being a post hoc ongoing study of long-term outcomes. And so I'm going to switch gears and talk about some literature now that's sort of detailing endoscopic thoracic discectomy and looking at sort of, is it safe, does it work, and is it as good or better? So this was a paper that was published in the Red Journal a few years ago. This was a multicenter retrospective case series and meta-analysis looking at endoscopic versus traditional thoracic discectomy. The primary outcomes that were examined were perioperative complication, the need for instrumentation, and reoperation rate. And the authors found that endoscopic thoracic discectomy was safe and effective. It significantly diminished your length of stay, as well as invasiveness, and it showed a decreased complication profile and infection rate compared to traditional open. So here, the retrospective endoscopic case series had 41 total patients, and it compared a meta-analysis of pooled data of traditional patients that were just shy of 3,000. Important to note that the symptoms that our endoscopic case series had are evenly distributed between myelopathy, radiculopathy, or both here. And then, just knowing that the over 90% of the thoracic disc herniations really were caudal to the T7/8 level here. And then also central disc herniations made up about half of our endoscopic patient cohort. So just knowing that even with central thoracic disc herniations, endoscopic thoracic discectomy was proven to be safe and effective. And also with spinal canal stenosis of greater than 40%, these are what's described as your giant disc herniations. And yes, thoracic discectomy via an endoscopic approach is also safe for that. And about a third of the patients made up that cohort in the endoscopic group. This is a pretty busy slide, but this is a same day. This can be a same day procedure, and so there were about a third of patients who actually underwent this surgery with local anesthesia alone under monitored anesthesia care. And then this, I'm not sure if you can see this, but this asterisk is showing that the complication rate for patients who underwent an endoscopic thoracic discectomy was about 9.7%, as opposed to 25% in the traditional open cohort. And so looking at your secondary outcomes, this length of stay, I think, is incredible here. In the endoscopic cohort, length of stay was on average 0.43 days, as opposed to 7 days in the traditional cohort. And I think that has some far-ranging economic implications, especially if you think about, sometimes insurance companies are going to pool these same patients in the same DRG. And so, the economic implications are pretty significant. And then looking at your visual analog score, the improvement post-operatively was definitely comparable between the two groups. And so I think this was a fantastic paper. I mean, the authors sought mainly to report the safety profile and compare endoscopic versus open. And so logically, the next step would be to look at your long-term functional outcome measures. And so I'll get into a little bit about that later on in my talk. This was another paper, meta-analysis looking at safety and efficacy in full endoscopic thoracic discectomy. The authors looked at 13 articles, which included about 285 patients, and their follow-up ranged from 6 to 89 months. They found that there was an acceptably low incidence of adverse outcomes in patients undergoing full endoscopic thoracic discectomy. So about a 1.3% pooled incidence of dural tear, 4.7% incidence of dysesthesias, and this can largely be related to thoracic radiculopathy with some nerve root irritation postoperatively. Recurrent disc herniation was found to be at 2.9%. Myelopathy, epidural hematoma, reoperation, acceptably low. And important to note that all these patients, there were zero infections, and I think that's a result of the continuous irrigation that is used for these endoscopic cases. And then this is the final paper that I'm going to talk about here just very briefly. This was a paper that was published in World Neurosurgery looking at the complications of endoscopic thoracic spine surgery. This paper, important to note that uniportal as well as biportal thoracic spine surgery was included, and not just transforaminal thoracic, but also interlaminar thoracic for, let's say, thoracic stenosis or thoracic lateral recess decompression were also included. And so the authors found that thoracic endoscopic surgery was viable, it was effective, it's ultra minimally invasive, and it's an option that provides a favorable clinical outcome for selected patients. They noted that these surgeries were technically challenging, and complications do arise, and when they do arise, they were pretty serious. But the decision making in terms of when to employ a endoscopic approach versus traditional open should be based on some pathological factors. So size, location of the disc consistency, whether it's a very calcified disc, whether it's migrated rostally caudally, all that should be taken into account, in addition to surgeon skill level and experience. So I'm going to be talking about showing some cases here. So this is a 17-year-old male who presented with gait instability, lower trunk and lower extremity paresthesias, and decreased lower extremity proprioception for about a week. Other than a positive Romberg, his neurological exam was non-focal. His MRI of the thoracic spine showed a left paracentral disc herniation at T45. It abuts the cord here. There's some cord signal change. CT of the thoracic spine showed that it was not a particularly calcified fragment or osteophyte, and you wouldn't really expect it in a 17-year-old, but it's always important to take a look at your CT for these thoracic disc herniations. This is a 3D representation, the 3D reconstruction of the bony anatomy here of the thoracic spine. Very important when you're counting ribs, looking at your bony anatomy in relation to your approach. I think treatment considerations, I think this could be amenable to a mini open transpedicular approach, but we opted to go for an endoscopic thoracic discectomy. I mean, it's just it really sets you up well to remove the disc with the least amount of collateral damage. And so important considerations here when you're doing an endoscopic approach, your incision is going to be just sort of at or lateral to the posterior apex of the ribs, not the lateral apex, but the posterior apex. And so at T5-6, an important consideration is the position of the scapula. This was a 6'2", 250-pound 17-year-old. So in all counts and purposes, an adult. And so we ended up positioning him prone on a Wilson frame. The Wilson frame, the bolsters were actually sort of medialized to allow the shoulders to fall forward. We tucked the arms and we allowed the arms to fall forward as well, just to bring the scapula sort of out of the way. I think that was a really, really important aspect of positioning for this case, because it allowed us to really make our incision and get our access starting point exactly where we needed to be. So this is the Jamshidi needle. Here's the spinal needle on the ipsilateral T1 pedicle. The Jamshidi is being advanced to the medial pedicle line here on your AP, and then at the posterior spinal line on your lateral. So we know that we're lateral to the dura overlying the spinal cord, and then we know that we're ventral to the spinal cord as well. So once we're passing the guide wire here, and we know that we're in the disc space, now we're sequentially dilating up and reaming to the medial pedicle line, and introduction of the working channel here. And now you can see the naked working channel here with the bevel facing inferiorly. So just to orient everybody, to the left of the screen is rostral, to the right of the screen is caudal, top is dorsal, and then bottom is ventral here. So this is the view immediately after introduction of the endoscope. So you're looking at the T5 pedicle. I'm not sure if you can see my pointer here, but the T5 pedicle is here. The ventral SAP of T5 is here. You can see just a little bit of the disc here, T4-5, and then your lateral recess and entrance into the spinal canal is going to be here. So this is a radiofrequency probe. It can be used for blunt dissection. It can be used for cautery as well. Think of it as like a bipolar they can use to dissect. So this is dissecting off some of the tissue overlying just in the foramen itself. And there's a combination of graspers that can be used to, clean up the area. And when so using the radio frequency probe, once the tissue's cleaned up and you're able to visualize annulus, what we did was a small sort of bipolar cautery of the annulus itself. And important to know exactly where you are based off your images from the endoscope. But always important to make sure that you correspond what you think your anatomy is with imaging. And so this is the radio frequency probe here on the superior end plate of T5. So thinking exactly where you are and then confirming it with your AP here, and you can see that yes, this is exactly at the superior end plate of T5. And then this is moving a little bit more rostrally here. A partial corpectomy is being performed here with the 3.5 millimeter diamond drill. And you can see that this is on the inferior end plate of T4, a little bit more ventral to the cord. And you can see, yes, on your fluoro, you're exactly where you think you are. So this is the mark, and just to reorient everybody, so this is the T4 vertebral body. A small amount of it has been drilled away. This is the T4-5 disc here, and then your pedicle of T5 is going to be here with your T5 body here. This is a pretty underrated move in the middle portion here, where the working channel and endoscope have been sort of pulled backwards, and this drill is being used to essentially widen the foramen to allow you a little bit more degrees of freedom of movement with your working channel, with your endoscope. And then this is just a closer up view of the drill. You can see this is a diamond abrasive drill, and it's a very safe and pretty effective drill that can be used even close to the neural elements. So part of the vertebral body of T4 has been drilled away. So a partial corpectomy, you can see annulus here. This little portion here is where the annulus has been bipolared away, and you can see sort of nucleus in this 17-year-old. It's pretty well preserved anatomy, non-degenerated. And so you can see part of nucleus here, and then lateral recess and neural elements is going to be right here. So this is a video, and let me just back this up here. So this is the defect in the annulus that has been created, and then we're just sort of getting in there with pituitary to remove some free soft fragments from within the disc itself. So once the portions of the disc have been decompressed, this is a grasper, and we're making use of the plane that's dorsal to the PLL here, and then decompressing the ventral aspect of the spinal cord. So I'm going to play this here, and you can see that pieces of disc are being removed, and with when just pause this here. So the egress port for irrigation, you can put your thumb over it, and when you take your thumb on and off of it, you can sort of change the pressure of the flow, and you can see the billowing of the neural elements here, just showing that you're slowly and sequentially decompressing it. And you'll see it once again, the billowing of the neural elements there. You're knowing that you're getting a good decompression. This is one of the last fragments that are being removed, teased away, but the probe, and then resecting it with the grasper here. And then, once we're pretty satisfied with the decompression, this is the grasper open. We're pretty central here, and it's confirmed with the AP fluoroscopy. This was a paracentral disc herniation. So once we know that we're central, we've achieved an adequate decompression. This is a before, that first image that was shown with the T5 pedicle, the ventral SAP, disc here, and then neural elements here. And then this is the after, where you can see partial corpectomy has been done. Good amount of disc has been removed. Partial corpectomy here as well in T5. And this is, dura overlying the spinal cord, so well decompressed. He was discharged home on post-op day 1. His lower trunk and lower extremity paresthesias were completely resolved, and his gait had stabilized. He was walking for most of the day without issue, and he was only taking Tylenol. And this is the sub-centimeter incision that was made on him. So a very, very good result, and I think a very, very elegant approach as well. Um, this is going to be a radiographic review for the next case, just looking at it before and after. So typically, we don't get postoperative imaging on these patients because, as long as they're doing well, there's really no reason to subject them to, let's say, a post-op CT or post-op MRI, not the greatest use of resources. And also they go home same day. But this patient, 63 years old, presenting with right worse than left anterior thigh pain and cramping, right-sided flank pain as well. She had a prior right T5/6 endoscopic discectomy in 2023, and so she's coming back with right hip flexion weakness and these types of symptoms. So this is her most recent MRI and CT. You can see that at T7/8, there's a disc osteophyte complex that abuts the cord here. Not terribly calcified, but at T910, she also has a very, very calcified disc osteophyte here that abuts the cord, deforms the cord, and on CT, you can see some marginal osteophytes here that contribute to it. And so looking back at her imaging prior to her initial surgery in 2023, you can see that at T5/6, there's a very calcified central disc herniation that was ultimately resected via transfemoral endoscopic approach. And this is her post-op imaging. So looking back at her pre-op imaging and then comparing that to her post-op imaging that was done a year later in preparation for her second surgery. So you can see now the spinal cord is well decompressed. And on CT, this is the extent of the partial corpectomy that was done. And then looking more paramedian, this is the foraminoplasty, if you will, just widening the foramen, allowing access with the working channel and endoscope. And so, if you look at what she had previously here and then compare that to her post-op image, you can see that radiographically, yes, this type of approach via endoscope, it can be very, very effective. So she went to the OR for a 2-level transfemoral endoscopic thoracic discectomy, and these are just some fluoroscopic images from the OR. The Kerrisons here hooked. This is a spinal needle on the ipsilateral T12 pedicle just for marker, and then this is the first level here, and making sure that yes, we're central enough with our decompression at the end. So she was discharged home same day. Her leg and flank pain had improved. She did endorse some postoperative right-sided mid rib cage pain, and I think that's due to some nerve root irritation, just from working in the foramen, but also when you're reaming to get to the access point, sometimes you have to ream the rib head as well in the thoracic spine, and so she could have some residual pain from that. It's improving with tramadol and lidocaine patch, but the ventral aspect of the spinal cord is well decompressed. Expect her to get much better. I'm going to compare and contrast these two endoscopic cases with traditional open approach. This is a 28-year-old male with progressive lower extremity weakness, paresthesias, had lower trunk pain and numbness, and real inability to walk. He was wheelchair bound, not really ambulatory. History was significant for a very large L4-5 herniated disc on the left, which required a discectomy in 2023 at an outside hospital. So he had some pretty significant proximal lower extremity weakness. He was myelopathic. He had a foot drop from his prior surgery, and a sort of a sensory level as well. He had numbness in his lower torso up to T6. This is an MRI which showed very, very significant ventral compression of the spinal cord here at T6/7 and T7/8. And as you can see, this is a pretty large patient as well. I think his BMI was 40. And on CT, you can just really see the nastiness of this of his disease. I mean, you can see osteophytes here that take up pretty much the whole canal at T6-7, T7-8. And not only is it at the disc space, but it also, travels rostally and caudally up the bodies as well. And so, given all this, and given the extent of the compression, this wasn't really amenable to a transforaminal approach. I mean, you'd have to go from bilateral. You'd have to do it at both levels. This would be an all day and then into the night affair. I mean, I don't think the safety of it would really be too amenable. So we ended up taking him for a two-level transpedicular discectomy with a partial corpectomy T6-7-8, and then instrumenting and fusing him from T5 to 9. Case went well. This is post-op CT, and you can see that the disc and the osteophytes at both levels were removed successfully. We did get into a durotomy here, which was repaired with Tacocil and Tisiel. He ended up doing pretty well. His lower extremity strength was preserved after this surgery. Thankfully, signals remained stable. So, all things considered, I think this was a good result from surgery. He was discharged to rehab on post-op day 9, but unfortunately, came back with a pretty significant wound infection that required a washout. And so I think this just details some of the complications that can arise from a traditional approach. Unfortunately, this is just collateral damage and expected sometimes from this type of large incision and in a patient with this type of BMI and wound healing issues. But thankfully, he was washed out. He continues to progress with balance and PT exercises. His ambulation quality and endurance is also improving from his last PT notes, and he'll come back and see us in clinic in about 9 months with the CT. And so I'm going to switch gears and talk a little bit more about the ongoing study of our long-term outcomes. And this is all possible via the Spine Healthy app. I think my co-fellow Mike Jensen gave a fantastic talk a month ago, just detailing the Spine Healthy app. So I'm not going to get too much into it, but this is an app that allows a patient to self-report their subjective and objective functional outcomes on a day-to-day basis. It allows them to track their performance and whether they're able to return to work, whether they're able to return to some of the hobbies that they love. And it also allows them to get in direct communication via text message with their treatment team. So kind of an all-in-one, app that allows them to really track themselves and get in touch with us. The Endoscopic Spine Research Group, or ESRG, these are the faculty across the country that have really been employing this Spine Healthy app and sort of maintaining this multicenter registry. And so looking at the data from this cohort of patients who underwent an endoscopic transforaminal thoracic discectomy, there were about 50 patients now that were tracked, and this is a sort of a VAS score of their back, so back pain VAS preoperatively and postoperatively, and the patients are self-reporting here. So postoperatively on the first 7 days, each day they're tracking and they're reporting, and then it kind of gets spaced out from the 2 week, 1 month, 3 month, and then 6 month, and then 1 year out. Sometimes the patients are going to sort of trail off and not really report, and so this is just a random sample of patients who have really, completed the questionnaires. And you can see that there's a trend of improvement here. As they get further and further out from surgery. I think the most significant improvement that you see really is between the 7 day and 1 month time point, where really they're able to see a good result of their surgery. So this is looking at the visual analog score of their back. When it comes to ipsilateral leg pain, it's a little bit less convincing of a trend here. And if you think about it, thoracic discectomy is really for treatment of thoracic myelopathy or thoracic radiculopathy, a little bit less so their ipsilateral leg pain, as it would be, let's say, for a lumbar disc. But regardless, you can see pretty stable in terms of their reported scores. And then between the 7 day to 1 month time point, you can see in some patients a good drop off. And looking at their ODI scores, their level of disability as well, there's a good trend towards improvement here. again, to between the 7 day and 1 month time point, really the biggest improvement. But a lot of these patients are coming in with a moderate to severe amount of disability, and it's very, very helpful to see them and track their improvement as they get further and further out from surgery. The steps data was actually something that I think was really, really important, especially when it comes to thoracic myelopathy. You hope to allow these patients a better chance to walk. And so in the data set, the patients on Swine Healthy were asked to report their steps daily for time point preoperatively, and that's in blue. So the average is taken in blue for pre-op and for post-op. And the delta here is in red. The analysis does show that, for these patients, there was actually an average delta that was negative when you compare pre-op versus post-op. So that means that these patients post-operative were actually taking less steps as they were completing their questionnaires. And what's a little bit confounding is that, some of these patients had self-reported steps scores for 2 years postoperatively, for 1 year, and then there were some who just reported a couple days or a week or two, and that was it. So a lot of variability in their self-reported duration. But I think this just showed this. So this was a paired t-test that was performed looking at preoperative versus postoperative, and yes, while this was significant, I think there's more sort of powerful analysis that can be done via ANOVA, because we're looking at the individual time points between pre and post-op and making sure that there's any sort of significance in those post-operative time points. And also, univariate regression can be used to get a better sense of exactly, if there's any sort of significance in this data. But more work to be done on the steps data. And I think just looking at the ODI and the VAS, I think there's a really, really significant trend towards improvement here that we can see with the Spine Healthy app data. So with that, I'm going to conclude. Just want to let everybody know that transforaminal is safe, it's effective for symptomatic disc herniation and the thoracic spine. It results in significantly decreased length of stay, EBL, and post-op pain. It's got a favorable complication profile and reoperation rate when it's compared to traditional posterolateral approaches. Special attention really should be given to disc herniation, location, size, consistency, especially in preoperative symptomatology when considering transforaminal endoscopic. Long-term outcomes do show that improved functional outcome in patients undergoing transforaminal endoscopic thoracic discectomy, VAS, and ODI scores. But further investigation of subjective and objective outcome measures with our patient-reported multicenter registry is very useful in determining long-term success.
Great, David. Thank you very much. That was an excellent, fascinating overview of transthoracic endoscopy. Questions? Anybody questions?
Hey, David, this is Christoph. Really nice talk. I really enjoyed it. In your mind, where do you think, the limitations are right now? I mean, you showed two cases, but where in your mind do you think we can advance on the endoscopic technique so that we can also tackle the second case and avoid that infection? So where do you think, what are the choke points? What do we have to change with the endoscope? What kind of tools will we need to kind of, tackle the more complex calcified discs? Where do you think we can do that?
Yeah, that's a tough question. I think just understanding the limitations really with the rostrocaudal extent of resection. You are a little bit limited with your working channel. The tools itself, I think it's very, very well engineered. But in terms of where we can improve, it you know wondering if visualization, looking around the corner and off axis, reach with the tools. I know there's the curved grasper that's in the Pro set, as well as in in the thesis set, but maybe tools with more of a sort of up-angled grasper or off-axis reach would allow us to really get sort of more rostrally migrated fragments, because the caudally migrated fragments, those can be done because your inclination angle is going to be looking a little bit more caudally. But it's tough to work rostrally because, one, you have to keep in mind the exiting root. You can't bang it up too much. But the off axis, I think, is one limitation with endoscopic in particular. And so just wondering if there's any way that we could design a tool that would allow just a more off-axis reach that could be pretty helpful.
Yeah, one other thing for that last case is you can also come bilaterally and do partial corpectomies and mobilize that fragment. Yeah, the only thing that we're missing there is, I think, as you mentioned, that the off-axis and articulating drills. So we're going to get a larger 4.5 drill. I think within the next year, so should be able to tackle even the case that you showed right now.
I had a quick question, David. Thank you very much. That was a wonderful talk. One of the critiques endoscopic spine surgery faces from some of our other colleagues is that of visualization, and that they believe that our visualization is not as good as microscopic or open. I know that you have quite a bit of experience with mini open tubular surgeries, now that you've done quite a bit of endoscopic stuff as well. How do you compare, the endoscopic visualization? Do you think it needs improvement? Do you think it's great as it is? And do you think that it has any effect on what we can do right now?
That's a very good point. Everything in endoscopic is going to be in 2D. Yeah, it's 4K, but it's 2D. So depth, especially keeping in mind that with interlaminar it's going to be 15 degrees on the endoscope, and then transforaminal 30 degrees. I think it really takes some getting used to. I think that for someone who really has less experience with endoscopic spine surgery, they're definitely going to critique it. And when you do it open or when you do it with a microscope, you're seeing everything in 3D. You're seeing everything very, very crystal clear. You have bimanual ability to use your tools, your suction, your Kerrison, and so that's a big, pro of being able to use things through a tube. But when you're looking through an endoscope, I think that the visualization is great, but it's just and sorry, Dr. Khan, was it those with a lot of endoscopic experience that were sort of critiquing the visualization, or was it those with less?
So I think when we try to convince people to adopt endoscopic techniques, one of the critiques from them has been visualization.
Yeah, and ultimately, I think that's just part of the learning curve. You have to learn how to use all these specialized tools, uniportal, right? And the visualization is also just part of the learning curve. And I think that with more and more experience, you're really able to tease out, okay, what's your depth? What's my reach? How far am I actually? And corresponding that with your X-ray. And just as more and more experience you get as a surgeon, sort of the better you're able to correspond exactly where you are in 3D with your 2D image on the endoscope. I think it's more of just a experience thing, like just thinking about where I was at the beginning of this academic year, and then kind of where I've been after this year. I think really this experience has been fantastic, and it just it takes some getting used to for sure.
Thank you.
Looks like there's a question in the chat.
See. Okay, so it looks like the question was about the approach to any sort of dural tears and CSF leaks that are seen during or done during surgery. So yeah, when a CSF leak occurs, you have a tear in your dura. It's obviously unfortunate. There are ways to repair it, and what I've seen is taking a very small piece of Duragen. Depending on how big the tear is, typically you're able to take a small piece of Duragen and then do sort of an inlay. There's let me see if I can show this here. Sorry, let me just pull up a part of my talk and it'll help. Okay, so the working ports, you're really putting one instrument in and out, but here we are here. Okay, so this is the endoscope here, and your working channel, or your working sort of port is this port right here, where you're putting in, your kerosene, your pituitary, but these two ports on either side here are mainly for inflow and outflow of irrigation. While your irrigation is going to be connected all the time to one of them, this other port here, you can, take a small bent K-wire and use that as sort of a second tool, with an assistant, of course, to allow you some more fine bimanual, manipulation. And so you have this port here, and then you have this port here where you can use bimanual approach. You can take a small piece of Duragen, with, let's say, a small pituitary, place it into the dural defect, and then hold it in place with your bent K-wire that your assistant can help with. And then with that, it's a pretty small tear, and so typically, with the Duragen, and then to seal, that can be placed through a longer sort of application tube, just immediately overlying the dural defect with the Duragen inlay. That typically allows for satisfactory repair of a CSF leak. And, keeping in mind that this is a very, very small incision as well. And so, once you get a good closure, typically these patients don't keep leaking. And there's not really any potential space to that any, small amount of, continuous CSF egress can really leak out into. And so that also really helps, just the ultra minimally invasive aspect of it.
Hey, David. This is Diana Wiseman. I just wanted to make a comment for the whole group on the socioeconomic side, especially as on my physician advisor side, where I do the insurance, like any of the denials that come through. So I will let the whole group should be aware from length of stay, what you said is very, very critical. More procedures are being taken off the Medicare inpatient only list, especially spine, so that they can be done at ambulatory surgery centers too. This includes like 2-level TLIFs. So recently we had a 77-year-old come in for a 2-level TLIF that insurance denied the case because we put in for an inpatient order and it's actually an OBS case and multiple comorbidities, et cetera. So it may not seem like an OBS case, but just so you guys know, this is out there, it's actively changing. And so procedures that allow us to do things quickly, allow the patient to get out of the hospital, will be very important in the minds of many institutions in the future.
Yeah, absolutely. No, it's a very, very good point.